Elkhatiali, who is going to talk to us about an interesting patient of his. And Hemit is working at Tygerberg Hospital, where he's been for the last 2 years, 2.5. Yeah. So yeah, take it away, Hemit. Thank you.
Okay. Just I will share my screen.
Perfect. We can see that.
Okay. Okay. So can you see the slide?
Yes, you can go ahead.
And the sound, is it clear?
Sounds good. Yeah, I'm happy.
Thank you so much. Thanks, Tim. Thank you for the introduction. I'm Dr. Elkhatiali. I'm one of the senior registrar at Tygerberg Hospital. So good afternoon, everyone. So I'm presenting the patient today as Alagille. I'm presenting the presentation as Alagille syndrome and the genetic diagnosis of cholestasis in infants. So I chose this topic and this presentation because if a huge dilemma regarding the diagnosis and regarding the management is specifically about the diagnosis. So it depends on the age of the presentation and age of the intervention for the diagnosis and interpretation of the diagnostic tools. So I will start with the patient. Case I am female, and the date of birth the 3rd of June 2022, and she was a preterm at 36 weeks plus 2 days, born via MVD, RVD unexposed, and also we tested to exclude HIV states, which is negative, and postnatal history, she was IUGR with a history of hypoglycemia that resolved with the frequent feeds after the counseling the mom because she was the first baby for her mother. And also she had a peripheral pulmonary stenosis diagnosed antenatally and confirmed on the postnatal echo with a planned cardiology follow-up. So the presentation, unfortunately, she missed her follow-up with the cardiology, and she presented to local hospital at age of 7 months. She presented with the jaundice. The T-speed was 155, which mainly conjugated hyperbilirubinemia. The conjugated bilirubin, it's 147 with the transaminitis, the AST 93, AST 166, and also she had a high GGT for her age. The GGT was 76, and the alkaline phosphatase 793, and also she had a bile stools, beer colic. She had abdominal distension with the hepatosplenomegaly. The time the sugar was normal, the normoglycemic, and not the liver failure. And she had a subtle dysmorphic features, prominent forehead and pointed chin. And also she had a bronchopneumonia and the chest X-ray. So at the time from the local hospital transferred to Tygerberg Hospital for further management and workup. So at Tygerberg, on assessment, she had a significant pruritus. It's all rash involved whole bodies, the scalp, face, and also the abdomen and the lower limbs and upper limbs. And also she had a pigmented stool. So the differential diagnosis at Tygerberg at age of 7 months, it could be Alagille syndrome in terms of pigmented stool, high GGT, and significant pruritus. Biliary atresia, which is unlikely because she had a pigmented stool, even she had a high GGT, but the stool was confirmed pigmented. And also we suspect the BFIC, progressive familial intrahepatic cholestasis type 3, which is I think it's a very early for her age at 7 months. So at the time the workup at the Tygerberg Hospital, it was a liver biopsy. We did the liver biopsy for her, and we sent the genetic study, and we did the fibroscan, which showed the liver stiffness 73.8, which indicate the early stages of cirrhosis. Ophthalmology screen, which showed no imperiotoxin. X-ray showed no skeletal abnormality. So in terms of the workup, also we did the abdominal ultrasound at the age of the 7 months. The abdominal ultrasound, the liver showed the liver heterogeneous and hyperechoic, no focal lesions, and portal vein doesn't appear dilated, but flow velocity couldn't be obtained. No focal cystic dilatation of the intrahepatic ducts. Gallbladder presented but collapsed. And maybe at the time she was feeding, and the spleen normal in size. Bilateral kidney are hyperechoic with the normal size, no hydronephrosis, cyst or calcification in the kidneys. And also there is no free fluid or lymphadenopathy on the ultrasound. So this is the ultrasound. It was at age of 7 months. I mentioned the date and the age because on the repeated ultrasound, we'll see some significant changes. So the liver biopsy, we did it at the age of the 9 months. So the histological, unfortunately, I couldn't get the slide from the histopathology lab, but this is the report for her. The histological picture shows appears to be cirrhotic liver with a bile ductal proliferation and chronic inflammatory cell infiltrate in the portal area. So according to the liver biopsy, the exact etiology of this is not identifiable. And even the histopathologist comment about the Alagille, it's difficult to exclude the possibility of Alagille as a classic ductopenia. So from the liver biopsy, we at age of 9 months, if we suspect the Alagille syndrome, it's supposed to be to see some changes like a paucity of the intrahepatic bile duct, but maybe because the liver of the cirrhotic liver at this stage, that's why we couldn't see the classic changes of the Alagille syndrome, which is a paucity of the intrahepatic bile duct. So then we send the result. We send already the genetic study, which came after I think 5 weeks, that's expected for any genetic study. It takes time and the cost also. So the genetic study it's confirmed as a JAG1, which is heterozygous and the pathogenic. Actually, they on this genetic study they check for the both genes for the JAG1 and the Notch2. But it's confirmed as a JAG1, which is a type 1 of the Alagille syndromes. So we got the diagnosis here, and we dig deeply in the history from the father's side, which we got. This is the first child for the mother, but from the father's side he had another wife, and he had I think 2 children passed away, which is supported the diagnosis of the autosomal dominant conditions. So at the time, the family were counseled about the diagnosis as Alagille syndrome, which is confirmed genetically, and it's type 1, and also counseled about the prognosis in terms of the quality of life, in terms of the follow-up, and they have to come as a follow-up, regular follow-up, and in terms of the nutritional support, and maybe for the liver transplant. And on that time, discharge on the fat-soluble vitamins and discharge on the anti-choleritic agents and antipruritic because she had a pruritus. So we discharged them also, and cholestyramine and rifampicin, and booked to follow up as our patients. So when we discharged her, she was a stable patient. We discussed with the dietitian, and she had a follow-up with the dietitian, and we booked her as our patient. So the second presentation to Tigerberg Hospital at age of 2 years, 4 months. Unfortunately, she lost the follow-up, but this is for long period. So it's almost more than 1 year because the family went to live in another province with her. And at this time, presented with history of abdominal distension, failure to thrive, and respiratory distress. We did the chest X-ray for the respiratory because of the respiratory distress, and we did the TB workup, and we sent all the hepatitis screen, which included the hepatitis C, which is excluded. Abdominal examination on that presentation was a distension with a hard, irregular liver, palpable liver, and we sent one of the workup. We sent the alpha-fetoprotein. So the alpha-fetoprotein came which is very high. It's more than 3 million microgram per liters. So the first top differential diagnosis at the time was a hepatocellular carcinoma within terms of the Alagille syndrome and the regular liver mass and Alagille and abdominal distension and high alpha-fetoprotein. So the hematology oncology was consulted and advised for MRI abdomen and fine needle aspiration biopsy under ultrasound guidance. So I bought, this is the X-ray for hair. I bought two just for comparison between the first one and the second one. I don't know if you can see the first one was on August 2021. And we see there's an increased cardiothoracic ratio, and there's an infiltration on the right middle loop. But for the bottom one, which we did it on the 2022, after she lost her follow-up, we can appreciate there is a multiple cottony dense infiltration with the interstitial pattern on the bilateral, but mainly on the right side. So the differential diagnosis from this X-ray could be metastasis and could be pulmonary TB and disseminated, which we excluded by history. There's no history of TB contact, and we sent all the blood and genetic gene experiment and sputum, which is negative. So we still concentrate about the metastasis from the chest X-ray. And this is the abdominal ultrasound. That's why I mentioned previously at the first presentation. So we repeated and at age of 2 years, after 2 years, large hyperechoic liver lesions with the multiple similar but smaller satellite liver lesions and splenomegaly, bilateral echogenic kidneys with the poor corticomedullary differentiation, and mild right hydronephrosis. So the differential diagnosis again from the according to the abdominal ultrasound, it could be malignant hepatic lesions such as a hepatoblastoma or hepatocellular carcinoma with a background of Alagille syndrome. So from ultrasound, we narrowed the differential diagnosis because we excluded the TB on the gene expert and sputum. And also on the ultrasound, we didn't, when the ultrasound, even the spleen, there's a splenomegaly, but there's no splenic granuloma, which is we kind to help to exclude the TB if we think about the abdominal TB. So the MRI abdomen done in 2022, as a hematology oncology team advised, there is a multifocal liver lesions, largest one on the left lobe of the liver. And this, which was informed the segment 4A and B with enhancement of the left and middle hepatic and portal vein. So the differential diagnosis, again, according to the MRI study, could be hepatoblastoma, hepatocellular carcinoma, or primary tumor with the liver metastasis. Also, they still reported there is a diffuse pulmonary metastasis, and fine needle aspiration under ultrasound guidance was advised, according to the MRI report. So this is the MRI video. I tried my best to share this video to see the nodules on the right and the left too. So I will start. I think the significant nodules, it was at a time of 19 seconds. And this is part of the chest. It is included in the chest also. We see there is a multiple nodules in the chest, also showed in the MRI abdomen. Yeah, so this is in the chest. There's mainly on the right side. We can see there's a multiple nodules on the chest, on the lungs. And when you go down, yeah, this is the nodules on the liver. It's involved in the right lobe and also on the left lobe with the different sizes. Yeah. Yeah, even here it's clear. One is under capsule. So according to the abdominal MRI scanning and the report. So we carry on with the fine needle aspiration under ultrasound guidance. So the fine needle aspiration, we did that on the 11th of November 2022. The aspirate consists of cohesive group of epithelioid cells that have haploid appearance to them. The cells are large with the ample cytoplasm and central enlarged nuclei with the nuclei, and also few bands of fibrous tissues also seem being associated with the cohesive groups. So the appearance from the fine needle aspiration biopsy, it can be a hepatocellular carcinoma or hepatoblastoma. So we discussed it with actually the report. It was showed by the hematology oncology team, and according to this all investigation, abdominal ultrasound, fine needle aspiration, alpha fetoprotein, so it's confirmed as a hepatocellular carcinoma. And this is the fine needle aspiration. We show that the haploid like cells with the large cytoplasm and also dark nuclei and the nuclei. So this is the histopathology imaging from the liver biopsy. So the further clinical course and the management for this patient, chemotherapy was started by the hematology oncology team, but the patient had poor response, unfortunately, and complicated by multi-organ failure. And the family was counseled and agreed on the palliative care plan, and the baby passed away at the age of 2 years, 4 months. So this patient had, we can't blame the family, but at the same time, it's a missed follow-up that makes that the diagnosis and the intervention is difficult for us. So we didn't see the patient for more than 1 year, which it makes the intervention for the chemotherapy or for the surgery, it's more difficult. So that's why the patient is complicated by the multi-organ failure at the time. So we'll come to the Alagille syndrome. Alagille syndrome, it has many names. It could be Alagille-Watson syndrome or arteriohepatic dysplasia. So the Alagille syndrome is inherited multi-system disorders that usually present in the first 3 months of life, typically manifesting as a cholestasis and potentially leading to the end-stage liver disease and death. So the first described by the Alagille et al. In 1969, and then by Watson and Miller in 1973, and again it comes back to Alagille et al. In 1975, which he put the diagnostic criteria for the diagnosis. So the genetic and pathogenesis, it's as I mentioned, as I mentioned, multi-system disorder. It's autosomal dominant with a defect in the notch signaling pathway. So there is a disruption of the notch signaling associated with the abnormal development of the intrahepatic bile ducts. Alagille syndrome, it's classified to main 2 types. So the Alagille type 1 and Alagille type 2. The Alagille type 1, which is more common, it's about 97% due to haploinsufficiency of the JAG1 gene, encoding the notch signaling pathway, ligand JAG1 on chromosome 20p12. So that mutation, it could be, it's either due to mutation with a large majority or deletion at the locus. Alagille type 2, which is very rare, it's less than 1%, are caused by mutation Notch2 encoding one of the Notch receptors, which are presented mainly with the renal malformations. There is another type, it's called Alagille-like syndrome, which is autosomal recessive inheritance, which is opposite to the type 1 and type 2, which is autosomal dominant, but not linked either to the JAG1 or Notch2, has been reported. I think the Alagille-like syndrome, it's reported in the native Canadian family. And also there is a small proportion of patients fulfilling the classic criteria. So we call this a phenotypic appearance or phenotypic criteria, but don't appear to have either mutation or deletion involving JAG1 or Notch2, which is making further genetic heterogeneity likely. So the next slide we explain some normal and the normal signal between the cells and the pathogenesis of the Alagille syndrome. So on the right side of the screen, there is a normal cells, two normal cells, and there is a signals between the cells. It can be the JAG1 protein or notch receptor. So regarding about the JAG1 protein and the notch receptor, it's working as a connector, as a passenger to transmit the signals between the cells. So the JAG1 gene, product JAG1, is involved in the signaling between cells. It connects with the adjacent cells via the notch receptors. After the two connect, signal pass between the cells to control the development of in growing embryo. Beside the eyes, because this notch gene it's involved in the eye development, also occur in the tissue such as the heart, liver, ears, and the spinal column. So if any disruption or mutation in this protein and the receptor, it makes lack of communication between the cells, and it give us the manifestation of Alagille syndromes. So as I mentioned earlier, the Alagille syndrome is a multi-system disorders, so involved many systems, but I think it's a 5 or 6 organs or systems involved. So it could be eye manifestation, it could be the heart, it could be the kidneys, cerebrovascular, and obviously facial manifestation, and this skeletal, it could be the liver also. So in terms of the percentage of the involvement, cholestasis is about 100%, facial manifestations about 70 to 89, and the heart disease about 80 to 95, skeletal abnormalities about 87, and eye involvement 56 to 88%, and renal anomalies, which is the least one, is about 73%. So in terms of the liver disease, which is one of the main diagnostic criteria, it presents with the chronic cholestasis in about 95%, commonly present in the neonatal period for the first 3 months of life, present with the jaundice, obviously it's conjugated hyperbilirubinemia, and also elevated serum bile acids and the liver function test. Pruritus, which is one of the main manifestation of the liver involvement, and growth failure. So for the liver disease, we have to do the liver biopsy, would typically show the paucity of the intrahepatic bile ducts. So in terms of the paucity, what's the paucity of the bile duct? It's the intralubular bile duct to portal tract ratio less than 0.5, and the normal one is between 0.9 and 1.8. But for the paucity, there's a challenge to diagnose, and the time in terms of the interpretation of the time, age, the time and age. So the paucity, it can be present in any other conditions. So a bile duct paucity appears to be progressive and may be more common in late infancy and early childhood compared with the early infancy. So there is a study about the serial liver biopsy have been performed. The bile duct paucity was present in the 60% of infants less than 6 months, and about 95% after 6 months. So in terms of the paucity, I think our patient, as I mentioned earlier, because the cirrhosis supposed to see the paucity clear in this age. About when we did the liver biopsy, she was at 9 months. So maybe because of the liver cirrhosis, that's why we couldn't appreciate the paucity of the intralubular hepatic duct. And also one of the manifestations of the liver disease, hepatocellular carcinoma, which occur even without cirrhosis, and the progressive liver disease with the cirrhosis and the liver failure, which occur in about 15% of cases. So condition associated with the paucity, that's why I mentioned the paucity. It's not Actually, it's one of the diagnostic criteria, but it's the problem with the time and with the age and with the differential diagnosis. For the paucity, it can be in the Alagille syndrome, non-syndromic paucity of bile duct, alpha-1 antitrypsin deficiency, and also in prematurity, Down syndrome, chronic rejection after liver transplantation, and it can be in cystic fibrosis and advanced phase of any chronic cholangiopathy and idiopathic. And the paucity, as I mentioned, it can be in the early, if you do the liver biopsy in the early, in young infants, we can see the paucity because of the prematurity. So the liver biopsy, if we consider the liver biopsy for the Alagille syndrome, maybe the best time we do it after 6 months to see the clear paucity on the liver biopsy. The second organ or the system involved after the liver, it's a heart disease. It's more than 90% of all Alagille syndromes. Patients present with a heart disease. The mainly is a peripheral pulmonary stenosis, which our patient diagnosed antenatally. And the etiology fell at about 16% of cases. And also there is another malformation like a VSD, ASD, aortic stenosis, and the hypoplastic left heart syndrome. So in isolated etiology of Fallets, so it's about 7% we were found to have a mutation in the JAG1. So from this point, so if any patient has a etiology of Fallet, maybe you have to screen for the Alagille syndrome because it's about 7% have a mutation for the JAG1. The third organ, ophthalmic features, present with all the ophthalmic features we diagnose with the slit lamp, so we can't diagnose by the normal ophthalmoscope. So present with the posterior umbriotoxin in 90% of patients, microcornea, keratoconus, congenital macular dystrophy, shallow anterior chamber, extropia, band keratopathy, and cataract. So when I was reading about the ophthalmic features in Alagille syndrome in terms of the quality of life and in terms of the complication, so the patient with the Alagille syndrome has a pruritus and have a poor quality of life, but the lucky things we see that I read that the ophthalmological features have a good prognosis. So if we treat the patient in terms of the pruritus and the nutrition support, so the prognosis for ophthalmology features, which has a good prognosis, that's good point for the Alagille patients. And the skeletal anomalies, it's a butterfly vertebra. It's about 80% of cases, and craniosynostosis and radioulnar synostosis, and shortening of the distal phalanges with the fingers that have fusiform appearance. So this is not for our patient because we did the X-ray for our patient and there is no skeletal malformation, but I got it from the website. And also we can see there's, I think, this X-ray for the spine, and also she had a congenital heart disease and corrected. And the facial features, for the facial features also the kind of challenge. It depends on the age, it depends on the family. Some the facial features will not appear clearly from infancy. So it's presented as a prominent forehead, deep set eyes with the moderate hypertelorism, upslanting palpebral fissure, depressed nasal bridge, straight nose with the bulbous step, and a large ears, prominent mandible, and pointed chin. So I did this different different photo for the facial features. Actually, in the adult age, if any patient would have Alagille syndrome, diagnosed Alagille syndrome, I think the facial features will not be clear in adult age group. And the renal features, it is presented in the type 2, which is a mutation in the notch 2, present with the renal dysplasia, renal abnormality as a horseshoe kidneys, and renal tubular acidosis also. So the other manifestation, it can be vascular events occurring up to 15% of cases, and where cause of death in 30%, which is significant. So in terms of vascular manifestations, it is a high cause of death in Alagille syndromes, if in terms of the intracranial hemorrhage. So the studies have identified anomalies of the basilar, carotid, and middle cerebral arteries, and renovascular anomalies, middle aortic syndrome, and Moya-Moya syndrome have all been reported. So this, according to the vascular malformation, if we have any patient, also the study recommended if we have any patient with a stroke and we have a manifestation of the Moya-Moya syndrome, maybe we have to screen him for the Alagille syndromes. So this is one of the significant complication of Alagille syndromes. So this is the systematic review regarding the epidemiology and the natural history and the burden of Alagille syndrome. It was a systematic review. It's about 525 screen published. From that, it's 20 medtech inclusion criteria. So from that, the systematic review, the liver-related feature included the cholestasis present in the 87 to 100% of the patient, joint is 66 to 85, and also the cirrhosis, which is significant, about from 44 to 95. And as I mentioned, pruritus affect about 88% of about 45 had a severe and refractory pruritus to cholinergic and antipruritic agents. And the pruritus can present during the first 10 years of life. And also children with Alagille syndrome had a significantly impaired quality of life compared with the healthy controls in terms of the pruritus, itching, nutritional, and also lack of sleep because of the pruritus, and also the family burden of the family burden of the patient. And between 15 to 47% of patients underwent liver transplantation, and 4 to 14% received partial biliary diversion, which we come to this point. This is the surgical management of the Alagille syndromes. So I put this table. I'm not going to go in details in this table, but I put this table, which is one of the interesting table regarding the diagnosis and the presentation. So from this table, what I can see, we can't comment about the phenotype or the manifestation to say this is a better, it's included, this is a classical presentation for the Alagille syndrome. So we can see in the first three studies in Alagille et al. And the Brett et al. And Emmerich, maybe they mentioned all the presentations for regarding of the cardiac murmur and cardiovascular complication and pulmonary stenosis. But in the last, I think in the bottom one, I saw many studies. They didn't see the pulmonary stenosis. They said not reported. And also renal and growth retardation, they didn't report it. Imperiotoxins not reported in many studies. And also characteristic features not reported in many studies. So what we learn from this table and this studies, we can't depend on the phenotype. We even if the patient has some features or he doesn't have some features, or we suspect that patient has Alagille syndrome, maybe we have to proceed with a genetic study instead of depends on the phenotypic diagnosis. So maybe we have to depend on the genotypic diagnosis instead of the phenotypic. So, and also this is another table. It's summarized the common secondary comorbidity report in the patient with the Alagille syndrome. We know all this complication regarding the cholestasis, bile duct paucity, cirrhosis, hypercholesterolemia, and pruritus just comes in mind. And now there is one study. I think his name is like a Vers et al., which he did a study on 163 patients, the number, and he got only one patient with the hepatocellular carcinoma. So all the study they mentioned, they're not reported or zero. So it's regarding the hepatocellular carcinoma, it's a rare complication, but it can be, which happened to our patient, unfortunately. So she presented she ended up with the hepatocellular carcinoma. So from this table also, one of the follow-up screen follow-up bloods to follow up any patient with Alagille syndrome. I think we have to do the alpha-fetoprotein annually and include the history examination and maybe the ultrasound, but we have to send the alpha-fetoprotein to pick up the raised alpha-fetoprotein early. At least if there's any intervention we can offer for that patient. Unfortunately, for our patient, sorry, I forgot to mention this point. We did the alpha-fetoprotein in the first presentation, which was normal, it was a 59. But after that, when he missed the follow-up for more than 1 year and we repeat the alpha-fetoprotein was more than 3 millions. So I think from this point, we have to follow up with the alpha-fetoprotein maybe annually or twice a year, every 6 months. So the diagnosis of Alagille syndrome is now defined by the genotype as well as the phenotype, and a significant clinical chance remain. So now the diagnosis, all the study, they depends on the genotype diagnosis instead of the phenotype, because we saw it in the last in the first table. This is not all the presentation is going to be classic and as a phenotypically diagnosis. So since the positive the bile duct histological diagnosis from liver biopsy occur in a diverse group of conditions, Down syndrome, cystic fibrosis, congenital infections, alpha-1 antitrypsin, and the Zellweger syndrome. So we can't depend on the liver biopsy also. So this is the second point. So we can't depend on the phenotype, and we can't depend on the liver biopsy. So this is the diagnosis. I like this diagram for the diagnosis Alagille syndrome. So it's diagnosed with the high, if we have any patient with a high GGT and cholestasis. So we have to put in our differential diagnosis Alagille syndrome. And if there's more than 2 phenotypic features, butterfly vertebral heart disease, so that's the phenotypic features, but we can't depend on, we can't depend on according to the last study, we can depend on the phenotypic features. And if there's a pigmented stool, so we exclude the biliary. So at the time, what happened for our patient was a pigmented stool and confirmed many times. So if we got the high GGT, cholestasis, phenotype, and pigmented stool, we exclude Alagille. I think we have to proceed with the genetic study. Maybe we have to start with the JAG1, JAG1, and even if there is a JAG1 is negative, maybe we have to continue with the notch 2. So this is the diagram again for the diagnosis. If there is a met classic criteria and we confidential clinical diagnosis, they said maybe the diagnosis confirmed. And also if there is a family testing anticipated, we have to do if there is a, on the left side, if there is no met clinical criteria, maybe you have to do the JAG1. And if it's negative, we have to consider the notch 2. And if it's negative, if it's still negative, the JAG1 is negative and the notch 2 is negative. So we have to consider either consider alternative diagnosis or Alagille phenoscopy or other Alagille genes, and consider the patient family for research. So even if we phenotypically still we suspect that Alagille syndrome with the cholestasis, facial features, or pulmonary, and but the JAG1 and JAG2 is negative, maybe you have to screen we have to screen the family, which was our plan for our patient to screen the father, but unfortunately they missed follow up. So to see if he has that gene, So the management of the Alagille syndrome, it's a multidisciplinary team between the pediatrician, dietitian, gastroenterologist, and the cardiologist. So there's the management is divided to medical management and surgical management. Medical management, it's included the nutritional support, fat-soluble vitamins, high-calorie diet, chloretic agent as orthodeoxycholic acid, which we call ortho, or phenobarbital rifampicin, bile acid binding agent as cholestyramine, antihistamine as the diphenhydramine or Alagille, opioid as an naltrexone, and lower lipid lowering agents, simvastatin, which is not recommended in the pediatric age group. So for the chloretic agent as an ortho and the bile acid binding agents, I think we have to be cautious about when we prescribe these 2 drugs, because one is chloretic and one bile acid binding. If the mother she's giving this medication at the same time. So it looked like we gave the medication and we chlorotic that one. So it's binding each other. And also for the bile acid binding agent, we have to give a space when we prescribe the fat soluble vitamins for the patient, vitamin A, vitamin A and D and K. So we have to give a space between the cholestyramine and the orthodeoxycholic acid. In terms of these drugs, we saw many patients they didn't respond to this medication. Actually, it's happened to our patient. We call this a kind of refractory pruritus. And also we have to consider the side effect in this medication. For the cholestyramine, I think the taste is not nice for the child to give him. It's a kind of the salt taste. And the phenobarbital sedative effect, rifampicin, it's a change the color of the urine. And also we think about it's a hepatotoxic, it's a rifampicin and antihistamine sedative. Naltrexone, it's one of the opioid drugs, and we have to think if we give for the patient, we have to think about the withdrawal symptoms and the lipid lowering agents, which is not recommended for the children. So the point from the medical management, we have to concentrate about the nutritional support, and we have to counsel about the medication. If we're going to prescribe this medication, we have to counsel the family, maybe this medication will not work. So that's the point from the medical management. So there is a new treatment and the new promise to treat the pruritus, which is the most annoying symptoms for the patient and for the family. So the new treatment is called the edoxipibate. It's as we know, the ileal bile acid transport is the regulator of the enterohepatic bile acid circulation. So these drugs, it's mainly work about the enterohepatic circulations. So the ileal bile acid transporter inhibitor, which is called this drug edoxipibate or maralixipate. So this drug, it gives a promise to in the pediatric age group regarding the maralixipate is now approved in the United States for the treatment of cholestatic pruritus in patients more than 1 year old. And odivexipate is indicated for treatment of pruritus in patients more than 3 months old, which is give us good promise in the future in terms of the medical management instead of the surgical treatment for the pruritus. So this is a trial for the odivexipate, and it happened. I think they did the trial over 8 months from the 31st of May till 26th June 2022. So they checked, they gave the medication, they gave the odivexipate, and they checked the serum bile acid and they checked the total bilirubin. We can see there's significant drops in the serum bile acid and also significant and the permanent drop on both in the total bilirubin and the serum bile acids. In terms of the colors of the change, the darkness, the color of this figure, I think they adjusted the dose from time to time. So they gave it 120 microgram per kg per day and 30 milligram per kg per day and also 60 microgram per kg per day. So this is going to be the promise in the future. I don't know when can we get this medication, but it's going to be a promise for all the Alagille patients in terms of the quality, improve the quality of the life from the pruritus side. So this is the course of the Alagille syndrome. So in the first week of life, it can be presented with jaundice, hyperbilirubinemia, transaminitis, high GGT. In the first year of life, it's a bile duct hyperplasia, mild fibrosis, elevated serum bile acids, and between the age 1 and 3 years, severe pruritus, which is one of the main presentation, abdominal pain, severe sleeping problem. That's why we say it's a quality of life. Splenomegaly, mild to moderate portal hypertension, and some, as I mentioned, there's no improvement in the ortho or naltrexone. So after the introduction of the edoxipibate, the IBAT inhibitor, there's improvement in the pruritus and sleep, reduced serum bile acids levels, and developmental progress. So the other part of the management is a surgical management, which if we failed with all the medical trials, so we have to discuss with the surgeon for the surgical management. It could be partial, internal, or external biliary drainage, and also the level if we fail with the medical surgical, so and the patient has a refractory pruritus, it's one of the indication for the liver transplant for the Alagille syndrome patients. So we finish with the Alagille syndrome, and this is the few slides about the genetic diagnosis and the genetic causes and the genetic diagnosis of the cholestasis in children. So this is the comprehensive, it's use of comprehensive 66 gene cholestasis sequencing panel in the 2,171 cholestatic infants. So this is the big samples collected from 2,433 and submitted between 2016 and 2017. And we reported the analysis that they reported and the analysis from that samples about 2,171 from the North America. So the panel overall diagnostic yield was 12%. So it's about 265 from that 2,000, so which is significant number, and represented 22 genes. The top genetic diagnostic for the group in order. So it was Alagille syndrome, one of the top top diagnosis. Alagille syndrome could be JAG1, Notch 2. Transporter defect included progressive familial intrahepatic type 1, type 2, or type 3, and also hepatocellular disease as alpha-1 antitrypsin deficiency, and the mitochondrial hepatopathy, and the bile acids like MBV17, which we start to see many patients here in South Africa diagnosed as MBV17, and also bile acid synthesis defect and the biliary disorder like a CFTR, which is one of the diagnoses for the cystic fibrosis. So this 66 genes, I think it's updated in 2017, because before they in 2017 they had, I think, six genes. So this is that the genes included the sequencing panel. I think from this panel we see almost of the cholestatic causes of the infants and children. So we see that there is a cause of the bile acid synthesis disorder due to a single enzyme defect, and also a cause of the paroxysmal disorder, including the Zellweger syndrome, included in this panel. And in terms of the other genetic causes of the cholestasis, ABCB11, which is BFIC type 2 or BFIC type 3, and CFTR involvement, and ATP8P1, one of the BFIC types, and included the Notch 2, JAG1, Niemann-Pick type C1 and type 2, and also the MBV17 involved in this panel. So if we have a facility for the genetic study, can you imagine how much we got the diagnosis and how much we save in terms of the time and the money? So if we suspect any patient if we see any patient with the cholestasis and we exclude infections and we exclude the surgical problem, so it's better to proceed with the genetic study if it's available. So in terms of the genetic testing, historically genetic testing was limited to the analysis of the single gene to confirm diagnosis based on the clinical observation and other assessment. We call the phenotype first. So if you see any patient, we have to see the patient phenotypically, and according to the phenotypically, maybe we have to send the blood to check that genes which we suspected. However, given the diverse etiology and the large number of potential genetic causes of cholestasis, single genes testing is impractical, inefficient, and expensive also, it's expensive, and the time it's if we send the genetic study, it's going to take a time. So what comes after that, the single gene testing? There's a sequencing next generation sequencing, NGS. So it could be it can be, for example, multi-gene panel, whole exome sequencing. It now enables testing for large numbers of the genes simultaneously, leading to the trend toward utilizing genetic testing early in the diagnostic process. So we suggesting the sequencing first. So if any patient come with a phenotypical, and as I said, it's a big dilemma between the phenotypical and the blood investigation. So we have to consider with the genetic study, and it's better to consider with the next generation sequencing. So this is the genetic disorder which can cause cholestasis in infants and neonates and infants, which is more common. So biliary tract, like Alagille syndrome, defect on the synthesis of the component of the bile as a bile acid synthetic disorders, and cholesterol synthesis defect intracellular trafficking like ARC syndrome, and MyoB5B-associated cholestasis. It's a MyoB-associated cholestasis that can be present with the chronic diarrhea and can be present later. And defect in the export of bile acid like tight junction, defect 1 and 2, 3, 4, 5, 6. And also defect of the metabolism, lipid as an imam big type, if any defect in the lipids metabolism as an imam big type C, or carbohydrate metabolism galactosemia, and amino acid tyrosinemia, paroxysmal disorder, Zellweger syndrome, and the mitochondrial as an MBP17. And also the causes, it can be the alpha-1 antitrypsin deficiency and the cystic fibrosis. So we still saw many patients with the Alagille syndrome. We saw the galactosemia, tyrosinemia, not that much, and the MBP17 and the cystic fibrosis. So all this is the genetic disorder which we can short the way in terms of the investigation and the workup to send the genetic study if we suspect any patient has these conditions. So the conclusion from my presentation: all the new studies support engaging phenotype before genotype before phenotype, especially because the phenotype of the cholestasis infantis generally is non-unique. So we discussed that many times about the phenotype. No, this is a subjective. This is he has a dysmorphic feature. No, dysmorphic feature. This is the look like a family. It's not like a family. So all this is the dilemma to depends on the phenotype. So it's all the study now. It's supported to proceed with the genotype diagnosis. And the use of a multi-gene panel is not only beginning to help the clinician and families with a timely definitive diagnosis. And we can say it's expensive, but we can say it's a rule out potential diagnosis, but also it's yielding a newly identified genetic variants which help in the study and the researches. So in terms of the genotype, I think we can say the genetic study, it's going to be the future of the future. So if we have any dilemma, so it's better to involve the geneticist from the beginning of admission of the child, and to save the time and to take other opinion to help that any patient with the controversially between the bloods and the phenotype and between the imaging. So it's better to involve the geneticist from the beginning of admission of any baby with the cholestatic jaundice. Okay, I think this is my presentation and this is the reference, and thank you for everyone, and we will come for any questions.
Thank you, Mehmet. It was a very interesting case and an unfortunate child to develop carcinoma. There is a question from Wisdom, and you can tell me if you want to tackle this one. So he says, thank you for the presentation. May you clarify the difference between a hepatoblastoma and a hepatocellular carcinoma, or how the pathologist can't differentiate? And then he wants to know from that, what chemotherapy, if any, was given and how is the patient being treated? So his question emanated from sort of not being clear about the final diagnosis and the fact that alpha-fetoprotein would be up in both the conditions. So it's difficult to distinguish as it's a non-specific marker. And Mehmet, do you want to answer that?
Yes, according to differentiate between the hepatoblastoma and the hepatocellular carcinoma, I agree with you. It's kind of difficult to differentiate between both of them according to the histopathology. But that's what we got the report from the histopathologist. They still, it could be hepatocellular carcinoma or hepatoblastoma, but when the decision to treat it as a hepatocellular carcinoma was from hematology oncology team. So actually, I don't have that clear answer for this question, how to differentiate according to the histopathology. Maybe I have to ask and to discuss with the histopathologist. In terms of the chemotherapy, I think when we check all the history of the blood and we have follow-up, I think they start vincristine, and unfortunately, she had a one dose, and then the patient presented with the multi-organ failure, so they decided to stop and to proceed with the chemotherapy.
Okay, thank you. Yeah, I think also just as patient background matters here, and the fact that there was existing liver disease, I think would predispose you more to the HCC.
Yeah.
But I'm also not an oncologist, so I may be speaking out of turn. Wisdom, does that answer your question?
Thank you. I think I was hoping we would have a pathologist on the platform, because I would think the features on microscope for a hepatoblastoma and a hepatocellular carcinoma would be easily differentiable. But I think he has answered in the context of the limits that he has. Thank you very much.
I think, can I just add that this was not also a biopsy, this was an FNA that was organized by the oncologists. And I think for them, the dilemma was they see so many young patients with hepatoblastoma. And while they acknowledged this was a young patient who had cirrhosis of the liver and an underlying predisposing condition for hepatocellular carcinoma, they wanted to be very sure of the diagnosis. But unfortunately, the aspirate that they obtained, the pathologists were not able to definitively say that it was definitely hepatocellular carcinoma. So I think perhaps if there had been a core biopsy, there would have been better certainty regarding the diagnosis. But I think given the fact that the child already had established cirrhosis, we were all fairly sure that although it's incredibly unusual in such a young child, that this was hepatocellular carcinoma.
Yeah, thank you for that. I see Liz's hand is up as well.
Yeah, thank you. I mean, it was a fantastic presentation and really good. I just wanted to ask you a simple question, really. I mean, the patient was on URSA, the child's got cirrhosis. You were already talking about the cholestyramine and giving it different things. Do you think it was valid? I mean, was any benefit of being on URSA, which is, we battled to get it in a child who's cirrhotic?
Thanks, Dr. Les. Yes, I think I agree with you. It's because, see, when we saw the patient with the later presentation and he has a refractory pruritus, we tried that also. I agree with you about the liver cirrhosis, but we try to improve the pruritus. And our plan to follow up the patient if there is a response or no. Unfortunately, the patient missed follow up. So that's what I agree with you. Maybe we have to consider to stop the ortho, but the patient, unfortunately, she missed follow up to see. So we couldn't judge if there's a response or no, or if there's any. And even the liver cirrhosis wasn't, and the early liver cirrhosis wasn't the FibroScan and the liver biopsy. But in terms of the response to and the decision to stop or continue, it was during the follow-up at the clinic. But unfortunately, she missed her follow-up.
Thanks.
Okay, thank you for that.
Thank you. Thanks, Liz, for the question. There is another question. Sorry, it just disappeared. There it is. Juliet asked, why is an FNA not done at the same time as the fine needle FNA? Why didn't to do a needle biopsy, basically? I think that's probably also a question for the oncologists. I don't know if you have more to add.
No, actually, the decision about the fine needle aspiration biopsy, it was from oncology, hematology, oncology, and with the radiologist intervention help. Yeah, actually, we didn't take a decision on that time about the biopsy. Yeah.
Okay, yeah, I think, I mean, that's a good point, because, you know, you are putting the patient through a procedure. So you need to get maximize your chance of a diagnosis. I'm not sure. But again, I'm speaking out of turn. So any other questions or comments? Thank you so much to everyone for attending. I'm glad you all had power at the same time. I don't see any other questions, so I'm going to close, and I want to thank.
But there is one more hand. Prof.
Sorry.
Nell's hand is up.
Oh, Etienne, sorry, go ahead.
Hi, Tim. Yeah, just a comment on the FNA needle biopsy. I mean, there's a significant difference in the morbidity attached to a FNA and a needle biopsy. And if you are thinking of HCC, FNA, at least as a first round investigation, is much safer than a needle biopsy, particularly, yeah. So I'm also not quite sure if you are going to do a needle biopsy, why you would do FNA. So, you know, I can't see doing both. It's going to be either or. And if you are concerned about the patient's how stable he is and complications, then the FNA, you know, is a reasonable first line investigation.
Yeah, and having, or given that he's already got distant metastases, I suppose it's also got to add into your equation and on whether you're going to do potentially dangerous investigations. Okay, now I'm going to make doubly sure that I'm not missing any other hands. I don't see any. Thank you very much, Mehmet. Thank you for the excellent presentation. And to everyone for joining us. Thank you to Echo New Mexico and Echo India team who does the logistics. We also want to thank the Gastro Foundation, and they will have the talk available as a recording on the website. And thank you to our sponsors. And then next week, the topic will be HCC. Thanks, everyone. Good night.
Okay, thanks. And thank you for everyone. Thank you so much.